Hey everybody, this is Terry Kuti with DipeCFoundation. I am very honored this morning to have my own breast surgeon here today, Dr. Michele Ley. Dr. Michele Ley is a fellowship-trained breast surgical oncologist with Tucson Medical Center. I want to tell you about the topic of our conversation today. We're going to talk about how patients are given information about breast reconstruction at the time of a breast cancer diagnosis. Dr. Ley was my first point of contact, and she was the first one who gave me information about all of my options for breast reconstruction. As many of you know, if you've read my blog, you know that I chose DipeFlap, but there are other options, and it's important to find out about all of them. Dr. Ley will address this also, but I want you to know that it's very important that the breast cancer is treated first. So I'm going to let Dr. Ley take over, and welcome this morning, Dr. Ley. Thanks for joining us.
Thank you for having me. I'm excited to be here.
Thank you.
So when it's determined that a patient needs a mastectomy, there are a couple different things we have to talk about. And the first thing I like to talk about is what kind of mastectomy you need. Some people are candidates for skin or nipple-sparing mastectomy, where we keep all the skin. We call the skin envelope.
Yes.
And then, but some people are not candidates for skin or nipple-sparing mastectomy. And the decision on whether they're candidates or not is based on a number of things: the size of the cancer, whether they might need radiation, and then also the breast shape and size. Sometimes age plays a role, but really nipple-sparing mastectomy can be done in lots of different age groups. So that's the first discussion, is what kind of mastectomy are you going to have? And then I mentioned radiation. That's another part of the discussion, is will you need radiation? That doesn't always change what kind of reconstruction you have, but it's important to have a discussion about it. We know that implant-based reconstruction with radiation, in the setting of radiation, whether it's radiation in the past or radiation for the current cancer, has a complication risk of about 30 to 50%. That doesn't mean every complication is a terrible complication. Sometimes they're minor complications, but it's important that patients understand that when they're making their treatment decisions. Some patients with that information would decide that they would not want implant reconstruction and choose something like a DipeFlap or tissue, other kinds of tissue reconstruction. So after you've talked about the cancer treatment, then we talk about what kinds of reconstruction there are. So there are basically two categories: implant-based reconstruction and tissue reconstruction. And there are lots of different kinds of both of those. Our group is currently doing both the retropectoral, or where the implant goes behind the muscle, which is the traditional way of doing breast reconstruction. But we also are doing prepec, or where the implant is on top of the muscle. And then we do, for autologous reconstruction, we do latissimus flaps, not too many tram flaps anymore, and then the DipeFlaps. A lot of times the DipeFlap reconstruction is done at a separate surgery, so that's important for the patient to know. And the other thing about multiple surgeries is that it's been shown that patients have an average of 3 surgeries when they're having breast reconstruction. So I think that's something that doesn't get told to patients a lot.
I agree.
And so I really make an emphasis on that it's an average of 3. That means it could be 2, which is what we hope it is,
Right.
but it could be 5 or 6. And so it's important for patients to understand that, because it's not a one-shot deal. It doesn't happen in 6 months. It can be a year or longer for reconstruction.
Yeah, I think sometimes I've heard the term one and done, and I think that's a little bit of a misconception with breast
I think so
reconstruction.
too. There is direct to implant reconstruction. We don't do that in our group, but there are lots of people that do it. But that doesn't necessarily mean that you're not having a second surgery.
Right.
And then the final thing is that, does the patient even want reconstruction?
Yep.
That can be very difficult to decide when you're in the midst of your cancer treatment. And so sometimes we do the mastectomy without reconstruction, and the patient can have it done later if they change their mind or if they weren't sure to begin with.
Right.
So that's part of the discussion too, is what is it like to not have reconstruction, and can I have it again later? And both of those are things that we talk about.
Wow. You know what I felt like? I felt like I was kind of back in time, almost 4 years ago in your office talking about this. This was all discussed with me in Dr. Ley's office, and why I'm so appreciative that I was given all of my options when I went in. And she told me that day that I was facing a mastectomy. And let me tell you why. It is overwhelming as a breast cancer patient to get that information. And when I walked into her office that day, I wasn't in very good mood, was I?
No.
No, I wasn't.
But most people aren't.
No, but I have to tell you the difference in the way I felt when I walked out of Dr. Ley's office, because I walked in thinking I'm facing a mastectomy. I walked out knowing what my options were to reconstruct my breast. And so I had a sense of hope. I didn't have to make that decision then, but that's part of the mission of the foundation, is to give the education to women and men so that they can make that informed decision. Dr. Ley, thank you so much for joining us today.
You're very welcome. Thanks for having me.
Great conversation. Absolutely.